Hello, good morning, good afternoon, good evening, wherever we are in the world. Welcome to Meet Menaca to celebrate you. Thank you so much for being here. Today, we are having the Meet Menaca episode 57, Asthma and Related Diseases with Professor Raj K. Rajakulasingham. Before we go into that, today I have a plea for all of you. We know this little girl who is 4 years old and battling for life with leukemia. If any one of you would be generous enough to go and support her by seeing whether your stem cells are matched, it would be a great help for all of us, because it can happen to any one of us. And, I can only say it would be a personal plea from myself and the Meet Menaca team for you to be able to go and so I'm going to play this clip from which came in the ITV for you for a minute.
This is how Isha should be living her 4-year-old life, singing and laughing at her home in East London. But she was diagnosed with a rare form of blood cancer in May. Her aunts can recall that awful phone call from Isha's mum, confirming leukemia.
You could just hear the pain and the heartbreak that she was going through. And then, so I was just, I don't even remember what I said, but I just knew it was not enough to comfort her. It's just our words couldn't put her at ease.
With COVID as well, it's been even harder. We can't go and see them, we can't support them, no one can go to the hospital, so it can only be the parent. So it's not like you can send someone else so they can have a break.
Isha is being looked after at Great Ormond Street Hospital, but 2 rounds of intense chemo has not worked. Her family now have just 2 weeks to find a stem cell donor to save her life. They're hosting drop-in stem cell swab events across London and say a match is more likely to come from someone of the same ethnicity, so of South Asian heritage.
If you are a match, if you're that life-saving donor, you'll be asked to donate via one of 2 methods. The most common, 90% of the time, is done through the bloodstream. It takes about 4 or 5 hours, and our donors say it's really painless, really easy, and such a simple way to potentially save someone's life.
To save this life, time is of the essence. But from her hospital bed, Isha keeps the faith.
Thank you everybody for praying for me to get better, and I'm going to come home quickly.
Prayers Isha's family hope will be answered as they continue their desperate plea to find a donor and save their much-loved little girl. Jennifer Dicchio, ITV News.
So thank you so much for bearing with us, but I think it was a powerful thing for me to be sharing. As parents, we have cousins, we have nephews, nieces. Please, spread this message as much as you can, and hopefully this little girl will get the stem cells what she requires. And I can totally feel the pain of the family and the parents, what they must be going through. My team will be sharing the posters where you can go and find out whether you are the perfect match. So if you can share it on the Dropbox and Facebook, and I have been always sharing for the past 2 weeks on all the social medias. So please, a request for you guys to take this very seriously and support her as much as you can. On another serious note, before we go into 10th of September was Suicide Prevention Day. And that is another point which is really close to my heart. As many of you know, I speak about my experience with mental health battles, and I'm being at the brink of it very openly, so that the taboo and the stigma around mental health just vanishes from our society, particularly from certain cultures than others, and everybody gets to speak about it, who are willing to listen and support those who are in that position. So to honor the Suicide Prevention Day, I want to observe silence for a minute, please. Thank you, everyone. Welcome to Meet Menaca, episode 57, Asthma and Related Diseases with Professor Raj Rajakulasingham. Thank you so much, being a professor, for bearing with us. Before we introduce you, a very warm welcome to you.
Thank you.
So,
Thank you for having me here. Yeah.
It's such a pleasure and honor to have you. So, the Professor Raj is a consultant physician and honorary clinical professor with a special interest in asthma, allergy immunotherapy, and general chest problems, working at Homerton University Hospital in London. Professor Raj is not only an award-winning expert, but also a passionate educator and author. After doing specialist training in respiratory medicine and allergy at the Royal Brompton Hospital, he took his training and expertise to Homerton University Hospital, where he went on to establish a dedicated allergy service. Homerton is now known nationwide as the Center of Excellence for all things respiratory and allergy related. And I'm sure a big credit goes to Professor Raj. So it's such an honor to have you on board today. I just thought I will share some of the facts about asthma before we let the expert share his experiences and knowledge with us. So for people who don't know, there's 5.4 million people in the UK are currently receiving treatment for asthma, including 1.1 million children. That is 1 in 11. And as adults, 1 in 12 of us are having asthma. Every 10 seconds, someone is having a potentially life-threatening asthma attack in the UK. And on average, 3 people die from an asthma attack in the UK every single day. As I told you last week, when I was introducing Professor Raj, I announced I have been diagnosed with asthma myself as an adult. So I am going to be listening all ears to what he has to say. So as we can see, asthma is very common. Asthma is the most common lung disease in the UK, as we already established, 1 in 12 adults in the UK, to be precise. So as an expert, Professor Raj, can you explain what is asthma?
Okay, so thank you for having me for this session. This is really nice to see some of my colleagues and others in this group. So essentially, the first thing to appreciate is that asthma is due to inflammation. So inflammation is a process which affects the airway of the lung, and that results in causing you symptoms. So it's an inflammatory airway disease. And remember, it's a chronic disease. So it's not like having an acute pneumonia, which you get over in a few days or weeks. But this is not like that. This is a chronic inflammatory disease, like having arthritis or rheumatoid arthritis or similar problems. And in addition, patients have symptoms like cough, chest tightness, or having some wheeze. So usually have probably going to be a combination of 2 symptoms or more. If you got that and also the symptoms continue to persist, then one does need to consider asthma as a possible diagnosis. So it's a chronic inflammatory disease. That's the most important thing I would say everyone needs to appreciate. Thank you.
Sure. Thank you. So, let's go into prevalence a bit. I know that boys are affected more than girls as kids, but for whatever reason, women are affected more in adulthood. So who gets asthma and what is the reason for this difference?
Well, essentially it's multifactorial. So it's not just one factor brings asthma on. I would say one of the most important things in causing asthma is the genetic predisposition. So your own genetic makeup. So that means your father or mother or both parents, if they have asthma or similar allergic diseases, then there is a chance that the child could end up in developing asthma. And in addition, we also know that children in the age group, from 1 year or 2 years onwards, getting recurrent or repeated chest infections may also predispose them to develop asthma or similar problems later on. So that's another problem, children getting recurrent or repeated infections. And the other third thing to remember is environmental factors, like several allergens, like pets, dust mite, pollen, and so on. So this is another third important factor. Then one does need to consider maternal factors like smoking as well. So if a mother is a smoker, then there is an increased chance of your child being an asthmatic when born. So it's a multifactorial problem. So that's the first thing to appreciate. There's no single reason why one would develop asthma on its own. Usually we would say it's an interaction. So it's an interaction of your genetic makeup with the environmental factors or the other factors, and that what brings the asthma on. So there's no single straightforward answer by giving one line reason. Yeah.
Sure. Thank you, Professor.
And the other question you asked is why more boys and then girls?
Yes.
Essentially, I would say if you take the prevalence of asthma until the age of puberty, then the boys tend to be more affected or are more common in being affected by asthma. And what happens around puberty is then the sex hormones come in. So once girls mature and become adults, then there is a change in the pattern of the sex hormones. So we think it's the sex hormones behavior, why then the women tend to get more of asthma after puberty. So before puberty is more likely boys tend to be being more affected. Then after puberty, then it's going to be women. Then what happens is once you reach menopause, it changes again because the sex hormones, again, as you know, no more there once you reach the menopause. Then what happens is late in your life, then the men get their share of it. So you tend to get more difficult asthma as a man after the age of 40s and 50s. So we think, although there's no one categorical answer, we think it's all to do with the behavior of sexual hormones in the human body, why this kind of discrepancy tends to occur. Thank you.
It's good to know. It's very democratic and it's equally distributed between both the genders. Thank you so much. So some get asthma as children and some get it as adults. So for those who get it as children, sometimes it disappears later on. And even in some cases, reappears later on. So what are the reasons for this? Because it's a bit bizarre for people who don't understand. Why would it disappear and reappear, and what really goes on there?
Yeah. So as I said, so asthma is essentially a multifactorial disease. So it may be that in some people that multifactorial interaction doesn't happen early in your life. So you may have to wait until you become an adult for that thing to happen, where your underlying history, environmental factors, your genetic makeup, all that tend to come on later on and then cause the disease. That's one reason why some people may not get it early. The main thing is that children, obviously asthma is common in children, and there's a good chance that if you have a child who is 8 or 10 years old who got asthma, there's a good chance, good 30 to 40, 50% chance that your child may outgrow asthma beyond puberty once they become an adult. However, the main thing to remember, if you've got a family history of asthma or eczema or other hay fever, which is an overriding problem in the family history. And if you got ongoing environmental risk factors, like you live in an environment where you're surrounded by lots of pets and animals all the time, or you are constantly exposed to dust mite, or your asthma is a difficult one or a severe one, that it continues to cause problems, recurrent asthma attacks, and hospital admissions, and so on. Or importantly, this is something that for the parents to think about. If you are a smoker and you think it's not going to cause a harm to your child, you are mistaken. Remember, as passive smokers, being the children, they are also at risk of having their asthma continue to persist beyond their childhood. And also, essentially, infections. So if the children continues to get recurrent chest infections, that's also another predisposing factor for them to have the asthma continue to persist beyond childhood life. So it's a multifactorial reasons, starting from good family history of asthma, allergies, environmental factors, smoking in the family, recurrent infections. So multiple factors why I think in some children, asthma tends to continue to persist beyond their childhood life. On the other hand, you may have children where they get asthma mild, perhaps moderate, well controlled. They're well in between their attacks, not much of family history. They don't have much of environmental exposure, good management, no one smokes in the family. Well, that child has a very good outcome to grow out of it. So that's how I put it to you.
Sure. Thank you so much. I think because it's really, really important, particularly around the smoking, you said, because, you know, the passive smoking, you know, it's a big problem in these things. Going from there, like people display different signs and symptoms. So how can someone find out it's asthma? For example, my asthma didn't get diagnosed for a long time, as I only had a cough as a symptom, particularly during the seasonal changes, only after coming to the UK, so which is much later in my life. So what should people know about the different symptoms so that people can, be alerted, even the family around them, and think, okay, if this could be asthma, might be it is worth getting checked?
Yeah, I mean, it's kind of a funny and difficult disease in one way, because sometimes, or many times, it can be overdiagnosed. Equally, it can also be underdiagnosed. So that's the problem. So if you've got a bit of cough, if you go and see your GP, I think based on just one symptom lasting for a few days, clearly that cannot be asthma. So most of the time, and that's the reason why I think the guidelines have been revised such that we now expected that, mainly if you're a GP or doctor seeing a patient, you've got to give a bit of time to go through the symptoms. So usually you're looking at symptoms like cough or wheezy noise in your chest, chest tightness, shortness of breath, and you've got to have minimum 2 symptoms, not just single symptom like cough or shortness of breath. You've got to have minimum 2 symptoms. Importantly, the symptoms have to be what we call episodic. They come and go. They don't stay there all the time. If you've got those symptoms, and if you see your GP with those symptoms, then the GP must have a high index of suspicion to think about asthma. But that's not the diagnosis of it. Think about asthma. Then, of course, the GP needs to take it further by offering further investigations and then trial of treatment. Remember, trial of inhaled medications treatment. If your patient has responded well, then only one can say this is true asthma. So it's not a single step process. It may well take 2, 3, even 4 visits to a general practitioner to establish the diagnosis. So the guidelines have changed over the last 10, 15 years. So the time has gone where someone goes and sees the GP with a bit of cough. Say to your GP, look, I'm coughing all the time, doctor, what do I do? Then you're given an inhaler. That's not a good practice. So one needs to analyze all the symptoms carefully. Think about other diseases which can also equally present in the same way. There are several other diseases who can present with cough and equally shortness of breath or wheeze. So asthma is not a diagnosis by certainty, but because you have specific symptoms. So in a way, therefore, one does need to have some kind of expertise to deal with this problem. But again, it's a common problem. It can be easily diagnosed, provided the doctors take objective assessment in the right way. And nowadays we have clear-cut guidelines. There's no reason why an asthma diagnosis should be missed, provided everyone follows the given guidance. Yeah, that's what I would say.
Sure. Thank you so much. I guess it is, any healthcare is all the management is a partnership. So I think partly even I ignored for a while, thinking it's just cough comes and goes, because none of my family have any asthma. So I didn't think that was not the first thing which came to mind. Of course, you cough and cold, the normal, you just think, but I think it started with just every time I got a flu or cough and cold, it would trigger. But, later
that's
on.
important. So if you simply have just the cough, no other symptoms, then clearly there are several other reasons for that particular problem. So do not assume for a moment that it's got to be asthma. That's where people get it wrong. So you got to look for other symptoms. And in asthma, as you said, there are specific triggers. Patients may well say, when I play with the cat, I get symptoms. Or when I run for a bus, I get symptoms. When I go out in the winter weather in the morning, I get symptoms. We get postmen coming to see us because they go out in the early mornings in the winter and they typically have asthma symptoms first thing in the morning. So these are specific triggers and sometimes you may identify in these patients. So really what's essential is a good listening skills by the doctor and then putting those symptoms together to analyze them carefully and then take it further. That's really how I would put it to you. Sure. But cough on its own, no other symptoms, your cough isn't episodic, no specific triggers. One got to look at other reasons for the cough.
Sure.
Yeah. Sure.
For me, it was episodic personally, and it was seasonal changes. So it nicely brings me to ask you the next question about the triggers, because for me, it is the seasonal changes which triggers. Dust, if I open any new packet or anything like that, it immediately triggers. Of course, the stress triggers as well. So there are different triggers for different people, as much as I understand. You are the expert. So what would you tell the common public? What should they look for as triggers? And I think because it's really important so that they at least prevent or manage the episodes where it goes out of hand as much as they can.
Well, this is one of the diseases where I would say the public should be their own doctors in a way. I really encourage you to teach yourself about the disease, because when we come to triggers, it relies on public telling us, people telling us what makes the asthma worse. There's no hard and fast rule. Whatever trigger for your asthma is the same for the other person. It doesn't work like that. So we simply rely on each individual who come to see us and ask this question. In your observation, what makes your asthma worse? When you ask this question, then you're going to find a common answer based on all the epidemiological studies. That's where you get examples like dust mite comes in, pollens like spring and summer times in the European countries where the tree pollen or the grass pollen might bring it on. Even in the other times, the fungal spores might bring it on. In some cases, some of you may have heard about what we call thunderstorm asthma. When there is a huge thunderstorm, remember there was a story in Australia, in Melbourne, where then there was an asthma breakout. In an instant, there's lots of patients got admitted with asthma attacks. So it's multifactorial. And then in some people, it could be the pets, like a cat or the dog or the horse riding. So there are several what we call allergic triggers which might make the asthma worse. So that relies on patients, people telling us in their own observation. Or we can tell them, look, these are the known triggers, but you go home and look at it over the next few months and come back and tell us. Equally, then there are what you call non-allergic triggers. You don't have to be allergic to them. These are what we call irritants. People who might say, look, I'm just go out in the street and queue for the bus. Then there's lots of traffic pass across me. Then my asthma gets worse. That's pollution. So pollution is a big problem for many people. Yeah. So that's something the whole country, the population and the governments have to work on to reduce the pollution. So pollution is a well-known factor. Similarly, infections can be a trigger in some people. Whenever they get a cold or flu-like symptoms, the asthma gets worse. In others, it could be change in temperature. Some people would say, I can't go out in the winter weather because low temperature makes my asthma worse. Equally, higher temperature for some people. So honestly, it's multifactorial. So what triggers your asthma may not be the same for another one and may not be the same for someone else. So essentially, is your own experience what dictates, and then you are the master of your own disease's control. Then you need to decide how best to minimize attacks by minimizing exposure to those specific triggers. That's essentially how I would put it to people. There's no single medical answer from any of the doctors saying, oh, you got to avoid this, and your asthma is going to be okay. It doesn't work like that. In some people, forgot to mention, food allergy can be a potential trigger as well. Certain foods can make the asthma worse as well. So remember, therefore, it's kind of multifactorial. And in some, importantly, smoking, they know. When they are next to a smoker, even strong perfume. Sometimes I heard people come and tell me, I can't stand this person's perfume because it triggers my asthma, which is true, So essentially, you learn that kind of information from the patient. It doesn't come from me, it comes from the patient. Then we go back to the patient and say, look, these are what we think is your triggers based on what you have told us, and then is in your hands to make the necessary steps to minimize the exposure. I know it can be hard. Honestly, I have seen few patients who would say they cannot travel in a public transport because some people wear very strong perfumes. They can't sit next to that person. So they do prefer to travel in their own car, which is true. Yeah. So I've probably said a lot of things here. Yeah, sorry.
Thank you so much. Of course, it shows your knowledge. That's what we want to learn from you. So you mentioned food allergies, which is becoming more and more common for whatever reason. Either we are becoming more aware or it's becoming more prevalent. I don't know which one it is. You would perhaps know. So would you recommend people having a tolerance test in that case?
Yes, food allergy is on the increase. That's because people become more aware of it. And also, as I said, similar to asthma, is all about the genetic factor and the interaction with the food. So we're seeing more people for the first time even in adult life having food allergy, mainly to nuts and so on. So yes, if you got relevant symptoms, yes, then we have facilities to test you and then offer the confirmation. There's no cure. Except apart from that, we can offer tests to confirm the diagnosis. And we know in some people, food allergy also can make the asthma worse, indeed.
Sure. Thank you so much, Professor. So, we have now known what can cause asthma, what are the triggers, how it happens. So how can someone manage asthma? Is there a difference in managing asthma in adults and kids to begin with? And, as you rightly said, it is a partnership for sure. And people this is a disease people can manage themselves. But is there, as an expert in the field, and I'm sure you have spent years on this, what would you say about managing it?
Okay, I think it's like any disease. Understanding the disease is the most important thing. It's sad that even in this era, we have patients sometimes think asthma is all about treating like an infection, where you are given a course of inhalers and then take it for a month or two, and then you think it's all over. That's where the problem is. So as medical professionals, it's our responsibility to educate the public that, as I said, when you asked me the definition, that asthma is a chronic disease. That's the first thing one got to understand. It simply doesn't go away within a week or two. Once you understood it's a chronic disease, then one needs to appreciate that the treatment needs to be taken continuously. There's no such thing as you take the treatment for a week or two and then stop. It doesn't work like that. So it's the understanding of the disease what makes the difference. But sadly, we still see patients whom the doctors have given medications and the patients don't comply. So adherence to the medications is a big problem, is a big challenge. There are still so many studies to see how to improve adherence, so it's a big challenge. So once everyone understands that this is a chronic disease, it has no cure, although if you are a child, then you have a good chance of growing out of it. Until such time, the only way to keep your asthma under control is to take the preventive therapy. There is an inhaler which is made up of steroids, but is a very lower dose in micrograms, and is very safe. And one can take it for years and years without any problems. As long as you take these medications regularly, most of the time, you can keep the asthma under good control. So that's my main message. So adhering to the medications. The main reason why many people do not have that kind of benefit is because either they don't get the right information from the practitioners, or they do get the information, but they simply do not want to continue to take the treatment. It's their choice at the end of the day. As long as we have informed them accordingly, then essentially the patient as an adult has to make that decision whether they want to keep the disease under control, or whether they want to just keep having recurrent attacks. So that's a problem. So there are effective medications which are very beneficial in these patients. So my message is, appreciate it's a chronic disease. There's no cure apart from nature can cure it for you. However, effective medications are there as long as you continue to take them, and that will keep your disease under control in many of you. This is like treating diabetes or high blood pressure or rheumatoid arthritis. There are several chronic diseases. The underlying theme is the same. Appreciate these are chronic diseases. The management is long term. Yeah. So that's what I would say to you.
Thank you so much. When you spoke about management and compliance, do you think there's a gap between the patients and the healthcare professions regarding the detrimental effect if they don't comply? How often are the patients really aware what will happen if they don't comply long term?
Yes. So it's a challenge, isn't it? Depending on whom you see as well. So, and the expertise of the doctor and how much time they have to give the information. So if you're a GP and only got just 10 minutes for your consultation, then I accept it's a challenge. So this is where there are what you call focus groups and perhaps general practitioners get together they form a satellite kind of affiliation and put the patients together and go through what I call regular sessions to educate the public on asthma. So I agree. I mean, it's a challenge. I'm not saying I don't think there's an easy answer to tell everyone that there is a way to tell everyone that, this is what it's all about. Having said that, as a practitioner, there's always time in your hand. This is not a disease. It's going to go away within a few weeks. Yeah. So even miss that opportunity today, fine. Give another appointment in 3 months' time and make that appointment as giving further information about the disease to your patient. Explain the nature of the disease. Tell them what this is all about, how to prevent and minimize further attacks. Tell them what might happen if they don't take the inhaler, or tell them the benefit of taking the inhaler. So yes, so I would say the management of asthma, very much like other diseases, cannot be done in one consultation, But unfortunately with the COVID, with the lack of face-to-face consultations, it's become more of a challenge. Even in our clinic, when we see a new patient, we spend about a good 20, 25 minutes. I would say still it's not enough. It's not enough for some patients, mainly those who have language barriers and so on. That is still more of a challenge. So there are lots of studies and work going on, but it's an ongoing thing. So how to give information to the patient, how to put that information to the patient, knowing that the patient agreed and accepted and understood the outcome and what might happen if they don't take the treatment and so on. Sure. So it's a challenge. I mean, countries like Sri Lanka and India, where I have worked before, that's even a massive challenge, because how clinics are run there. People just queue up. There is no time for doing anything else other than just write a prescription and send the patient home. I mean, I'm not criticizing anybody, but that's the reality of healthcare in some of these countries. So compared to that, it's not better in the UK and European countries and American environment, but still, there's still more to do. There is still more to do.
Sure.
That's what
Thank you so much. Yeah. Because I was asking that question as a patient, because more and more commonly we see the nurses, unless until we have a acute attack, then either you land up in the A&E or you get to see your GP. Other than that, most of the time it's managed by nurses. And I
don't have a problem with it as long as the nurse whom you see has got the expertise in managing asthma. I mean, it's not an issue, sure. Whom you see, as long as the person has the actual knowledge and the expertise of it. So that's where the difficulty is. If you don't have the expertise, or the nurse doesn't have the expertise, and they are given the task to manage asthma, then it's a problem. Which I agree. So it's up to the general practitioners to decide how much expertise the nurses have to give that task. Yeah. I mean, as a dentist, I can speak because sometimes patients come with these inhalers. Of course, I have inhaler myself, and then they are never told they have to rinse their mouth after the steroid inhalers, and that can cause oral thrush and caries. Small, minute informations like that. Absolutely, a very simple thing: how to prevent oral thrush. How often that kind of advice is given by the medical professions to patients, just to say, gargle your throat after you've taken the inhaler, number one. Number two, use an aero chamber to minimize throat symptoms. So things like that is easily done, but clearly missed for many patients. I agree, indeed.
Thank you so much. So you have so much of experience. So as an expert, can you share a couple of case studies, how asthma was managed differently and how the outcomes then varied because of how they were managed, please?
Yeah, I mean, it's not two patients. I could just give you some examples. I mean, we see patients with asthma of different varying severities. So we do see patients with mild asthma, but then they get discharged back to the general practitioners. So mild asthma, like someone having cough and wheeze and shortness of breath, intermittent, and may not necessarily have so many attacks, and they take inhaled steroids like beclomethasone or fluticasone or mometasone, and they continue to take it. I can quote several examples. By complying with the inhaled medications regularly, they have managed to stop having asthma attacks. That's, and clearly they don't smoke. And even I've seen some patients after years and years and still continue to remain in good health. So that's a really good, positive, good outcome because they managed to comply with medications. Then I see patients on the opposite side where I still see a man in his 60s or 65. He's an Asian man. He runs a business near to where I live, where I work. So I know him by hand, who he is. And sadly, this man has got good education. He understands the disease. I don't know what it is, but every time you go and you see him, he says, sorry, doc, I haven't taken this inhaler after the first month. I ask him, why haven't you taken it? Oh, well, I just haven't taken it. Give me a good reason why you haven't. Have you forgotten to brush your teeth after a month? No, you haven't. So if you haven't forgotten to brush your teeth after a month, then this is very much like brushing your teeth. You just got to keep the inhaler next to your brush, take the inhaler, then brush your teeth. Then it's done.
Trust me, people forget to brush their teeth as well. As a dentist, I can say that.
Yes, indeed. So I kind of say that to him. But sadly, this guy has had several hospital admissions, even been to the intensive care unit 2 times. So then we have to, get the family together and get to go through this and get help from the family members. I think with their help and support and so on, finally he got around this problem. And pleased to say that he's now doing well. He's doing well. He's not relying on steroid tablets. And his main thing is not getting admitted to the hospital, and he hasn't done it for the last 5 to 10 years. So there are ways of overcoming these problems, but this is something we have to do in a difficult, hardest way to convince him that taking the inhaler is the way out of his problem. Unlike the earlier example I said, where the patients understood it well and they complied and they were fine. Yeah. Then of course there's another scenario where we have few patients, they comply, they genuinely take their medications. But unfortunately, they got severe asthma. Despite taking maximum dose of inhaled medications, whichever the doctors prescribe and so on, sadly, they still have ongoing attacks. They still get admitted to the hospital. They even get admitted to the intensive care unit. So this is not a major problem, but there is still a large number of patients in the UK who fall into this category of what we call severe asthma, despite being on optimal medications and having good compliance. So that's what I would put to you. So this is a kind of 3 categories of patients as an example.
Thank you so much. You explained it so well, and I think it is very, simple way for people to understand what differences it can make and how it can be managed. So thank you.
Yeah.
Does asthma progress and get worse, or can it be managed well? Because of course, we have spoken why it should be managed well. If it doesn't get managed well, what will happen? Because I think it's as important for people to understand so that they take that, it is another incentive for people to take the inhaler, I guess.
Yes. So as I said earlier, so if you're a child getting asthma, yes, you have a good chance you can grow out of it. So in that sense, asthma can get better. Equally, if you are an adult, got asthma, and if you remain untreated and you have ongoing symptoms with further asthma attacks, there is a good chance your asthma will continue to progress, and you may end up in having a further decline in your lung function and may develop a condition called chronic obstructive pulmonary disease, or COPD, or what we call fixed airways disease. Then none of the inhalers would work because there's nothing much to reverse, because you have sustained or suffered permanent damage to your lung airways. So in that sense, yes, asthma can progress essentially in some patients. And I have seen few patients where the poor compliance for the first 10 years or 15 years in their life sadly resulted in further worsening of their lung function. Every time you get asthma attack, remember, you're going to lose some fraction of your lung function. So as you grow older and older and older, you're going to lose more of your lung function. And that's the problem. So I would really say to you, if you've got ongoing asthma, there's no excuse for not taking your preventive medication. Yeah. So this is something you really need to bear in mind. This is like treating your diabetes. If you are prescribed insulin or tablets, you've got to continue to take it. Otherwise the consequences are not known immediately. 25 years time, you may have problem with your eyes. You may go blind. Your kidneys may fail. You may go into kidney failure. And so it's the same thing. It's exactly the same thing. Poor outcomes. So it's really highly evidence-based that asthma got to be treated and one got to comply and continue with the medications. Indeed.
Thank you. You mentioned COPD, chronic obstructive pulmonary disease. It can be a group of lung conditions we must, I think, all get familiar with. So COPD is known to be the second most common lung disease after asthma. According to the statistics, the prevalence has increased by 27% in the last decade in the UK. What do you think is the reason? I know smoking is the most common cause of the COPD. I am not an expert, you are, but my limited knowledge, I think 9 in 10 cases because of smoking. It's a scary statistic. 9 out of 10 cases of COPD comes from smoking. So, what is the reason COPD happens, and can stopping smoking prevent or stop it from deteriorating?
Sure. So just to go back to our medical school time, 33 years ago, perhaps, and when we were students, we didn't use the term COPD those days. So if you look at the textbooks written in the 60s and 70s, we used to call emphysema or chronic bronchitis. Then we had asthma in parallel. So that's a problem. So the terminology, number one, wasn't there. It's over the last 30 to 40 years, the terminology of COPD has come in. That's the first thing. The second thing is and the way how it was diagnosed is very different those days. Those days, people used to simply listen to the history and say, oh, you have asthma rather than anything else, and given treatment. So COPD wasn't properly diagnosed. As science advanced and the technology advanced, now we have clear-cut guidelines, which weren't there 20, 30 years ago, how to diagnose COPD. So my explanation is most likely that we are making the diagnosis more promptly, and we are picking those patients, more of it now, than how we did it 20, 30 years ago. That's the reason you see probably more and more cases of COPD on the increase in the last 20 years, unlike what it used to be before. That's the first thing to remember. So when I was a student, nobody taught me COPD. I never learned that term. I learned it as I became a doctor, when I became a senior doctor and so on. So that's the importance. It's a kind of a relatively a newer terminology. When you have a newer terminology comes in, it also takes time to make a diagnosis of that kind. That's the main reason why you're seeing more of it. Then, of course, those who smoked years and years ago, they don't get the disease then and there. So they get the disease about 15, 20, 30 years later. So we're seeing the after effect of smoking, although now people obviously know more about the harmful effect of smoking and so on. But remember, in the 40s and 50s, when you ask a smoker, does smoking harm your lung? The answer is no. You see James Bond used to smoke in the sixth screen, or most of the best films, they have a cigar in their mouth. So that's the fashion. Nobody, if you challenge anybody that is like COVID deniers, if you challenge anybody, that smoking would cause cancer or COPD, they will laugh at you those days, yeah? So it's taken a long time to recognize the harmfulness of smoking. But I agree, smoking is the most commonest cause of COPD. And remember, those who have uncontrolled asthma, where the disease progresses, they can become as having COPD at some stage. So asthma becoming COPD later on with fixed airway disease, which is also recognized. So that's another reason why perhaps we are seeing an increase in COPD. But remember, as you said, asthma is much more common than COPD. Some studies would put 8 million people in the UK having asthma and about 1.2 million having COPD in in the UK. So that's 1:8 roughly. But again, the numbers can vary a bit. Yeah, thank you.
Thank you so much. It's very interesting what you said, that COPD wasn't used as a terminology in the past. And because I learned COPD in the medical school, so I didn't know that, it wasn't.
Because you are younger than me.
I'm not going to ask you how old are you.
Some people in the group probably know that.
Okay, so I know personally, like I have read about this, and I know that life expectancy of someone who has COPD is a challenge. So what are the figures and how can it be managed really?
Sorry, can you just go through that question once again?
Of course, again, COPD, there's an issue with the life expectancy of someone who experiences COPD or who has COPD. So how can they manage once they go to that stage of COPD? What can be done actually?
Okay, so it's worth knowing a bit more about smoking. So just in general, if you are a smoker, your average life expectancy is lost by at least 4 years, whether you like it or not. Okay, that's the first thing. If you develop COPD on top of it, and if you got mild to moderate disease, unfortunately, you're going to lose further 4 years of your life. So altogether, you're going to lose about 8 years of your life being a smoker and has mild to moderate COPD. If you got severe COPD, the chances are you're going to lose about another 8 to 10 years of your life. Plus, remember, being a smoker also, you're losing another 4 years. So you're going to lose about good 12 to 14 years of your life. Why do you want to do it? Why can't you stop smoking? That's what I tell people. Why do you want to die 12 years prematurely?
And also the quality life before dying, isn't it?
Absolutely. So this is just about death. Then, of course, the quality of life is appalling, isn't it? I see lots of patients who got severe COPD and they just can't do much. They are very much symptomatic. They can't even tie their shoelace. Yeah, can't have a bath. Can't do their usual activities they used to enjoy. So the problem with the COPD, unlike asthma, COPD is something there with you all the time and having symptoms all the time. Unlike asthma, as said by definition, the symptoms are episodic. When you are exposed to triggers like infection or dust or whatever, then you get asthma attack symptoms. And most of the asthmatics are well in between. But COPD patients are not like that. They'll have to live with the symptom all the time. They just simply mostly housebound or very much restricted in what they can or cannot do. That's the difficulty. So there's, unfortunately, the cure, or rather, you asked me the cure, what can be done? Yeah, therefore, stop smoking is the main answer. Even though we see patients who got very much moderate to severe disease, stopping smoking even late part of your life does give you few years bonus to live, few years of additional years to live. So no time is late for you. Even you got an established disease, my message is please give up smoking. Despite me having all these wonderful inhalers, none of them make a difference in terms of mortality. It doesn't save your lives. The only thing what saves you life is giving up smoking. Of course, if you got end-stage disease and have low oxygen, then having long-term oxygen therapy might also save your life, improve your prognosis, I would say. So those are the two main things in COPD saves lives. That is giving up smoking, and those who got end-stage disease having long-term oxygen therapy. But not these wonderful inhalers. I know reps want to tell us about how wonderful these inhalers are and so on, but I can tell you, none of them would save your life. Yeah, they may make your symptoms better, but will not save your life. Yeah.
Thank you so much. I was so engrossed in the show. I know that we are almost arriving at the time when we have to finish. So
Sure.
What are the 5 things every single person must know about asthma and related diseases, and they will be compelled to go home and share it with other people?
Okay. The first message, if any of you ask message, understand the disease. Please appreciate it's a chronic disease and there is inflammation in your airway. It simply doesn't go away. Second message is know your medications. You got to know what you are taking. Don't say you are just taking an inhaler. Know your medication, know your preventive inhaler, and make sure you take it regularly. That's your second message. Number 3, monitor your disease, monitor your asthma. Nowadays, we do give what we call peak flow meter. So at least, and your symptom diary. So monitor your disease and see how well you are performing, like you monitor other things. Number 4, understand the asthma control. So one needs to appreciate what control means in terms of your symptoms, day-to-day activities. And the 5th thing, or the final thing I would say, make sure you have an asthma action plan. That's very important. Each and every asthmatic must be given and must have a written asthma action plan. So that's something a nurse specialist or a doctor can do. And it's very easy to do, and each and every patient must have it. So those are the 5 things I would say as a take-home message for anyone who is an asthmatic.
Thank you so much, Professor Rajakulasingham. It was like, I have learned a lot about asthma, and I definitely have some takeaways to tell people. I'm sure everyone on the forum has as well.
Thank you.
Before we move on to other things, following tradition, I am going to announce the speaker for the next episode. It will be the episode 58. It will be How to Manage Pain with the Dr. Naveen Rajadurai, consultant musculoskeletal radiologist who has also a specialism in pain management. He's graduated from University Saints Malaysia in 2004 before obtaining his master's in radiology from University Malaysia in 2012 and furthering his subspecialty training as a fellow in musculoskeletal radiology under the Ministry of Health Malaysia, training in diagnosing musculoskeletal disorders, predominantly sport injury, imaging, bone oncology, and rheumatological disorders. His interest then gravitated towards musculoskeletal intervention radiology, where he trained in hospital Sungai Buloh, performing interventional procedures related to pain control, therapeutic, bone oncology, and sports injury intervention. He also completed a stint of AORN training in spine intervention, predominantly vertebroplasty, kyphoplasty, and ozone intervertebral disc therapy with an attachment in SS Trinidad category. This is the only time I am grateful that I went to dental school to study. Otherwise, I would struggle to read these things. So thank you so much for enlightening us with such a thing. And I'm looking forward to him coming and talking about pain and management next week. Now, to give the vote of thanks, over to Dr. Kanta Niranjan.
On behalf of Meet Menaca, I have great pleasure to give the vote of thanks to a very good friend, colleague, Professor Rajakulasingham, who is an academic clinician and very passionate about teaching, and very good, very clear description, not using any jargons. And I'm really, I'm also as a clinician, but I really appreciate how a good speech can be given to the public, which you have done today. Excellent, wonderful presentation. During the COVID pandemic, the past 18 months, having seen a huge human tragedy, it is a good time now to start talking about common illness like asthma, especially before the winter starts, because it's a common disease and sometimes it's poorly managed because lack of knowledge and awareness among the public. So your talk today many of us will have take-home messages. I have learned something new today, even though I was a clinician. So like that, all of you have to take home messages to spread to others, to be aware of what the 5 action plans, 5 important message Professor Rajakulasingham has given. I like to thank all the great audience today. Without you, this platform is not a success. And also, before I finish, I like to say, I can see Professor Rajakulasingham has made many doctors, because he's a lecturer teaching medical students, and also have produced three very intelligent doctors. One of them was also in the panel today, in the forum today, Dr. Ramya Rajakulasingham, a budding cardiologist. It's very nice to see her, welcome her as well. One day she will give us a talk. Thank you very much, Raj, and I'm really very nice to have you today.
Yeah.
Yeah, thank you for having me. It's really appreciate sharing my thoughts on asthma with everyone else. That's the important thing, sharing the knowledge and the information.
Thank you so much, Professor Rajakulasingham. It's an immense pleasure and honor to have you on the platform. And now I know that you have very talented young clinicians in your family. I will be knocking at your door again, surely.
My daughter is already watching it, so maybe we could ask her another time.
Of course, definitely. You know that we have another speaker coming. As Kanta mentioned, most of the experienced clinicians, it's really amazing to see how they don't use jargons. And when I went to speakers training, the one thing which was told to me, if you can speak where a 5 to 6 year old or the maximum 12-year-old can understand what you're saying, then which means you know the subject inside out and you're thorough with it. And that's what you have established today. So thank you so much once again. For people who are on the Zoom, please hold on. We are not finished yet. You will be able to ask the questions straight to Professor Rajakulasingham in a minute. For people who are on the Facebook, thank you so much once again for joining us. And once again, my plea for Asia, if please support her and check your whether you can stem cell checked, and if it's a match, please be generous. It could save one child's life, and we all know what the pain of having a child who is struggling with something like leukemia. Next week, hopefully, we will see you, Dr. Naveen Rajadurai, who is going to be speaking about pain management. For now, for people who are on Facebook, it's that time of the day to say goodbye. Until then, stay safe, be happy, and keep smiling.